Yeah, it's 8-5 you start.
Yes. Sir, the patient is 69-year-old, resident of the road, came with chief complaints of swelling over both scrotum and penis since 1 month, and also complaints of staining towards since 1 month.
So it is a 69-year-old male patient who has presented with external general swelling and straining towards. So I'd like to think in terms of prostatic etiology for both. If it is not associated with any other swelling, then we can think of some lymphatic blockage due to prostatic pathology and also causing lower urinary tract symptoms. I would like to know more about this swelling of the genitalia and more about lower urinary tract symptoms. In the swelling, whether it is associated with any lower limb swelling or generalized anasarca, abdominal distension, and early morning puffiness of the face. And lower urinary tract symptoms, I would like to know if there is any urgency, frequency, urge leak, intermittency, sensation of post-void residue, and is there any associated hematuria? I want to know, sir.
Would you like to know whether this swelling is painful or painless? Has it been specified there? Has it been specified?
No, sir.
Yeah, so before you go off to all sorts of history, first ask things which are very, very localized. So is the swelling painful?
In the history of presenting illness, they have mentioned not associated with pain, sir. And there is no fever also.
Yeah, so if you already know the history, then there is no point in discussing the history. But if swelling comes,
so we are not able to hear your voice, sir, breaking.
carry on, go ahead.
Okay. No. He also complains of straining towards since last 1 month and associated with other voiding and storage LUTs. Frequency, urgency, nocturia is there, incomplete sensation is there, intermittency and straining is there. Total IPSS score of 15.
What is the highest IPSS score, man? Possible?
So 35.
What is the meaning of this IPSS score? What do you gain out of doing all this?
So that is symptom severity index, sir. How much bothersome patient is having symptoms, sir?
Okay.
Bothersomeness of the symptoms.
What is the classical symptom of bladder outflow obstruction?
Sir, it is more of storage symptoms and little.
No, what is the classical symptom? Before all this IPSS came in, prostatic enlargement was there already.
Yes, sir.
Many people don't even use this score. They use clinical judgment. So I'm asking you, what is the symptom which is sign qua non of bladder outflow obstruction due to BPH?
Sir, urgency, frequency, sir.
Wrong.
So this was one of the questions I actually answered during my residency. You had asked me. So I'll answer that for them. It is overflow and straining.
Okay, sir.
See, the classical symptom of BPH obstruction is hesitancy, which is worsened by the postponement of micturition and overflow. Correct. If you ask the patient very clearly and without mincing your words and make it very clear to him, if you tell him that ask him if he's got starting trouble, and if his starting trouble becomes worse if he delays urination, And as a result of which his flow is also poor. You got your answer. You don't need Euroflow, you don't need anything else. We're only talking of BPH, we're not talking of anything else. Alright. Carry on.
Okay, sir. There is no other significant history mentioned, sir.
Okay.
There is no increase or decrease in size of the swelling and change of posture, sir. That is less likely because of dependent edema. His known case of diabetes mellitus since last 8 years on oral hypoglycemic drugs, and also hypertension since last 3 months on tablet amlodipine. His bowel habits are normal. He has no substance abuse, and the patient is not sexually active. There is no significant family history. Yeah.
So what's your summary? You want to tell us the findings also?
Sir, at this stage of the history, sir, the 69-year-old male patient presenting with external genital swelling and straining to void with significant lower urinary tract storage and voiding lower urinary tract symptoms. I would like to think in terms of prostatic etiology causing both the symptoms, sir, and especially the.
But what prostatic etiology will cause the swelling of the genitalia?
Sir, prostate cancer can metastasize to the external iliac lymph nodes, causing retrograde blockage of the lymphatics that can cause external genital swelling without causing lower lymph node involvement also.
Nice. Is that a very common cause of swelling of the genitalia?
No, sir. Hypoalbuminemia, and he has no substance abuse, so liver pathology can be this stage can be excluded, and he
only
also
alcohol produces liver disease. You said substance abuse. I presume you are talking of alcohol.
Yes, sir.
Only alcohol produces liver disease.
No, sir. Most commonly is the etiology.
He has no substance abuse, therefore he has got no edema, no liver problem.
And also there is no associated abdominal distension suggestive of ascites, or there is no lower limb edema, lower limb swelling, or early morning puffiness of face is also not there, sir. So other generalized causes for swelling like edema are less likely, sir. I want to look for any local cause.
The way you will answer this question is if you're looking at localized edema versus generalized edema, isn't it?
Yes, sir. Yes, sir.
So you can't have localized edema if you have got only liver failure or kidney failure. The generalized edema.
Yes, sir.
So because he's got localized edema, you want to think of a local cause. If you answer your question specifically to that point, then the examiner says, okay, this fellow knows he's sort of got all his algorithmic stuff ready in his brain. He's able to think properly and without getting confused. All right, carry on.
And I'd like to know the examination findings. So,
tell us the examination.
Karnowski's performance score is 100%, sir. His vital signs are normal, and spine examination is also normal. Abdominal examination shows no palpable mass or suprapubic fullness. No flank tenderness also I assume. No tenderness I mentioned. Genital examination shows normal meatus and glands, normal penile shaft. Both testes are normal and located in the scrotum. There is diffuse swelling over the scrotum and penis. So
this diffuse scrotum swelling over the scrotum and penis. With that, you are able to examine the glands and penile shaft and everything in the meatus.
If there is significant swelling, it is unlikely they could have examined, especially the glands and meatus.
Oh, you haven't seen the patient. This is just the findings.
Yes, sir. There might be minimal swelling.
No, if you are saying there's diffuse swelling over the scrotum and penis, then how can we say that the shaft is normal, the glans is normal?
It's difficult to appreciate the underlying like.
Both testis is normal in size. So, anyway.
And digital rectal examination.
Telling of the scrotum, right?
In the digital rectal examination, there is grade 1 prostatomegaly with hard consistency, and median sulcus is not obliterated. So I assume this hardness is in both the lobes of the prostate, and rectal mucosa is mobile over the prostate. No induration felt in the rectal mucosa, and perineal sensation present. Bulbocavernous reflux is present, sir. So hard prostate is there with external leg. Sir, I would like to do a lymph node examination at this stage, sir. I would like to palpate for inguinal group of lymph nodes followed by iliac group of lymph nodes, sir. External and internal iliac group of lymph nodes.
You want to palpate?
Yes, sir.
Easy to palpate?
I would like to try, sir. If it is positive, then
swelling and all that. How fat is this guy? Is he very thin?
It is not mentioned.
No. See, you stick to the inguinal region, which is very easily accessible.
Yes, sir.
But if there is a lot of edema and everything else, then that also will not be accessible, isn't it? So you have to say that. Don't mention about external iliac lymph nodes unless it's very, very obvious. And that has to be palpated very, very quickly, because you have to just palpate right over the inguinal canal. The inguinal ligament.
Yes, sir.
It may not be felt all the time. Sometimes you are feeling other things which we think. So you must be very clear that you are palpating the external iliac lymph nodes. If you can say it, if it's very clear, then only mention it. Don't mention it. You mention what is generally felt in the inguinal region.
Okay.
Can you feel any inguinal nodes? That's also not mentioned.
Not mentioned, sir. And also, I would like to examine the lower limb edema, fitting edema,
Right.
and peripheral sensations. There is any vascular insufficiency is there, especially venous insufficiency.
Okay.
Next. Sir, in the examination, in the investigations, I would like to get complete blood counts and renal function test, urine analysis, and urine culture done first. And also, I would like to get serum PSA for these patients.
Right.
Total. In the hemoglobin is decreased, anemia is there, and total counts are normal. Differential counts are also normal. Serum creatinine is slightly raised, and blood urine nitrogen also raised, probably acute raise in the renal parameters. And they have done low LFT also, that seems to be normal, and serum electrolytes are within normal range, and potassium is slightly on the upper part of the normal range, and HbA1c is 9.7. He is a known diabetes patient, and it is uncontrolled. Serum PSA is more than 200 nanogram per ml. Sir.
Yeah, we could read all that. You could have summarized that and said that the investigations show that the most significant thing there is the PSA. Isn't it?
Yes, sir. Yes, sir. You can raise in PSA.
And 1.4 may be on the upper limit of normal for that hospital, whatever the range is.
No.
That's it. Yeah?
Yes. Urine analysis and urine culture. The urine analysis shows turbid urine with 10 to 12 pustles is there, sir, and also significant microhematuria is there, 3 to 4.
So why do you think he's got turbid urine?
So that may probably due to this significant post-void residue, which is causing stasis and
okay, because he's got. What is the reason for that post-void residue?
Sir, bladder outlet obstruction due to prostate.
Yeah, because he's got more storage LUTs. Okay.
Yes, sir.
Right.
And urine culture is no growth, sir. So this pyuria, this pus cells also may be because of stasis only.
What's your plan?
Sir, his serum PSA is more than 200, sir, and
Yes.
his a hard prostate in the digital rectal examination. So I would like to do an trust-guided prostate biopsy, sir.
Straight away. Straight away.
So I'd like to get prostate biopsy first, sir.
So
And
he's
later,
coming to the OPD, you tell him I want to do biopsy for you.
I want to do an ultrasound abdomen also, sir, to look for
You want to ultrasound abdomen to look for what?
sir, to look for upper tracts and costoid residue, and if there is anything can be picked up from the
No, no.
ultrasound.
What is your diagnosis here?
So carcinoma prostate
It is carcinoma prostate unless otherwise proved, isn't it?
yes, sir.
Right. So what is this ultrasound going to help you?
For upper tracts, I would like to.
If the upper tract is dilated or whatever it is, it's equal to carcinoma prostate. Will that help you? What is the idea when you are suspecting malignancy?
So staging the.
Staging, right? Will ultrasound help you to stage?
No, sir.
Then why don't you go for the investigation which will help you to stage the disease?
Sir, I would like to get MRI abdomen and pelvis with bone. This one, sir, prostate biopsy and bone scan, sir.
Listen, boss, you go step by step. You are flying like the Tufan mail. In the exam, just take it easy. Go step by step because some fellow will catch you at some point and say something else. So, this man has got a high PSA. I think with the hard prostate, he's got malignancy there. I would like to, first of all, stage it and I would like to then prove it. Isn't it?
Yes, sir.
Yeah.
Sir, if there is a PSA like this, more than 100 or so, when the metastatic disease is already evident and the trust-guided prostate biopsy proving the cancer, do we need to do local staging also, sir?
You tell us.
Well, you don't want to.
You tell us.
No need to do local
No
staging.
need. You've already given him the death. Finish. He's got performance status, he's 100%, man.
Yes, sir.
Is it? You mean according to you, there's nothing you can do apart from just doing biopsy and giving something else, tirtham.
So, which is why you should go step by step. First, you will do a biopsy.
Biopsy.
Okay. Or with a PSA of more than 200, what else can you do first?
PSMA PET.
Is that standard of care?
No.
PSMA PET, right. I knew you were going to say that. I knew you were going to say PSMA PET.
What is standard of care to look for bone metastasis? As of
Bone scan, sir, but without histopathology.
what bone scan?
So that is sodium F18 bone, sodium fluoride bone scan, sir.
Can you do an MRI and still make out bone mets?
Yes, sir. It is more sensitive but less
Can you stage
specific.
with an MRI?
Yes, sir. MRI will also.
Why is staging important today?
The staging one is to.
According to you, there is only one treatment for this man. From the way you are progressing.
The staging is important because it will guide us for the treatment and also for prognostication.
That is the most important thing. Forget the prognosis part of it. It will tell you the way you have to progress and treat this man. Things have changed dramatically in prostate cancer. Huh?
Yes, sir.
This fellow has come fresh to the clinic. Okay?
Yes, sir.
Huh? He has got such a high PSA that he's probably metastatic. So he comes into a different category altogether, isn't it?
Yes, sir.
Huh? And therefore it is necessary to stage such a patient If he's a decrepit old man and nothing is wrong with him, that's a different matter. You have said his performance state is 100%.
Yes, sir.
You got to give him 100%. Huh?
69 years.
I know, you 69, whatever. You got to give him that, keep that performance status going, so you got to give him the best shot that's available.
Yes, sir.
Whether he can afford it and all, that's not part of the exam question, okay? In the exam, we don't talk about cost of treatment. We talk about treatment. So staging is important because it will, with the MRI, you will be able to find out exactly whether he's got bone mets because it will tell you skeletal survey. You can get marrow infiltration. You can get lymph node disease. You can look at liver. You can look at every damn thing because you will be then able to target which type of treatment you will go for. You understand?
Yes, sir. Understood.
Yeah.
Praveen, what do you think the MRI will show?
The MRI will...
Taking the clinical picture.
So it is likely that MRI will show... anyhow, we are not going to get the MP MRI, so only plain MRI T1, T2 images we are going to get. In T2 images, so prostate, there will be hyper intense lesions in the prostate. And in the local lymph node enlargement, especially in external iliac, I am expecting external iliac lymph node.
That's an important reason for you to do an MRI.
Yes, sir.
Isn't that because this man presented with edema of the scrotum, isn't it?
Yes, sir.
And your clinical impression was that there could be something with lymphatic drainage, and you talked about some retrograde spread and this and that.
Yes, sir.
So you have to find out that, man. So the MRI will tell you that.
Yes, sir.
Yeah. So it is an investigation in this patient. You cannot say I will do, I will not. Okay?
Yes, sir.
What else will MRI do? Answer Prabhu's question.
MRI also tells visceral metastasis is there, and also bony metastasis also we can make out, sir.
So will you like to do a MRI? No, will you like to do a biopsy first or a MRI?
I would like to do MRI first, sir, because biopsy will alter the MRI findings. So otherwise, we have to wait for 3 weeks and then do an MRI.
Hang on. Again, you must be very clear of what you're saying. What the statement that you made is correct. However, you have to look at the statement in the context of the case.
Yes, sir.
Okay, you would use that analogy in somebody who you think is got
Localized
prostate cancer, which is amenable for definitive localized treatment. That means localized prostate cancer. You want to be sure that there's nothing else wrong with this fellow's prostate going outside. Therefore, you would do the evaluation before you stick a needle in. But here, the man with a PSA of 200, you're suspecting metastatic disease. It is highly unlikely that you will go for something like radical prostatectomy and blah, blah, all those things. Okay?
Yes, sir.
Yeah. So, you have to be clear about what statements you are making. That's why
Yes,
don't fly. You take step by step. You know your theory, but you have to apply it correctly.
Okay.
So, Dr. Prabhu's question.
Yes, sir.
So what you will do? Biopsy first? Or?
MRI first, sir. Followed by that.
So will you do a truss-guided biopsy or just a finger core biopsy?
I would like to do truss-guided biopsy, sir.
You will take 12 course or you will take 24 course?
12 course and take.
You will take 12 course.
Yes, sir.
Why do you want to take 12 course?
So when we are doing first time prostate biopsy, sir, and the 12 course is the beyond 12 course there is no increase in yield of the cancer, sir.
Right. See again, you haven't got your funda right. What Dr. Prabhu asked you a question,
Yes, sir.
and then you again made a statement which is not wholly correct. He asked you a question. You will do truss-guided biopsy. How many? Whether you will do finger-guided or whether you will do truss-guided biopsy. Isn't that what Prabhu asked you?
Yes, sir.
sir.
Yes. So you answer the question. Will I do finger guided biopsy or will I do trust guided biopsy?
Trust guided biopsy.
Why you don't want to do finger guided?
Sir, I want to diagnostic yield is more with
Yeah, you are rattling the theory. What we are telling is, now you have a patient who has 200 PSA, who has probably any core you take, you will get a CA prostate, which is much more likely than whatever statement you said with the trust biopsy is for early CA prostate. The yield is definitely better. But in this case, where you have PSA 200, rectal examination showing hard prostate everywhere, you think you want to
See,
put 12 course?
the only way you can get out of this question and this answer that you made is by saying that, sir, by doing a trust guided biopsy, I will protect my finger. That's all.
okay, sir.
Finger guided biopsy, I may hit my glove, I might hit my finger, and I have all shit on it. Okay? So that is the only way you can get out of it. That's a very genuine reason. We wear 2 gloves, we wear 4 masks, all that. But when you want to do PR, we put half a glove only. And then stick a needle in. So, trust guided biopsy is the best way to do it because you will protect yourself, you will see the target properly and you hit it. But the question is whether you take 12 cores or whether you take 2 cores or 4 cores. Alright?
Yes, sir.
While most people might be brave enough to do a finger guided biopsy,
Yes, sir.
which is one way that you can protect your finger by and still not do a trust guided biopsy. I don't have trust, but I want to protect my finger. What is the way to do the biopsy?
Perineal biopsy.
Yeah, transperineal. Okay.
Yes, sir.
So you see the way you can answer these questions is thinking slightly laterally. That's all. You know that these are the ways of doing. If I ask you a question, what are the ways to do a prostate biopsy? You'll answer the question. Okay?
Yes,
But
sir.
when you have it slightly different, you guys all get stuck.
Can I treat this patient without a prostate biopsy? I'm very sure about
Very
it.
good question. Very good question.
No, sir.
Can I treat this patient without doing a biopsy?
No, sir.
Can I treat it on emergency basis?
There is
Yes,
a
sir.
patient right now in our hospital who I have treated without doing a biopsy. I started treatment without doing biopsy.
So if there is a impending spine fracture or
Pending spine fracture.
spinal compression,
How do I know?
we have to do MRI spine.
So first you'll send for MRI. In your hospital, you have to send across the city to do an MRI. You'll do that first for impending spinal cord compression.
The patient is developing neurological symptoms like sensory numbness or weakness of the lower limbs.
You still haven't answered Prabhu's question. Can you treat him without a biopsy?
Yes, sir. In emergency, we can treat.
So,
What emergency?
no. How can you treat him? Emergency or no emergency? How can you treat him without a biopsy?
His PSA is more than 200, sir, and heart
Oh,
prostate is there. What?
No, man, that's not the answer.
Sir, orchidectomy, I would like to do.
You will be taken to the cleaners, man. If you do orchidectomy. Huh?
So tomorrow it comes that finally he's got a prostatic abscess which caused the PSA to go up so high. You've done the orchidectomy.
Can you put it back?
No, sir.
So question was how can you treat it?
Fine. We can administer Degarelix.
What is the advantage of Degarelix versus orchidectomy in this situation?
It is reversible, sir.
That's the only reason, man. If you, of course, I know of many urologists who have such a good rapport with the family and with the patient that they would do an orchidectomy without the biopsy. But in the exam, don't say that. In the exam, you have to say that you cannot do an orchidectomy without a biopsy.
Yes, sir.
Right? So, the way to answer this question is use medical management. You can use bicalutamide, you can use all the other hormones, all these things are in a situation where can be reversed. You don't lose anything.
Yes.
And as Manish said, you have to look at the clinical scenario. Impending paraparesis. That means he's already got some degree of numbness, L5, S1, 2, 3. He's got some minimal. Clinical examination will tell you.
Yes, sir.
Alright? So that is his bladder is distended, painless. You put a finger in the rectum, apart from heart, prostate, he's got some stool impaction. So these are things that will tell you. And he's got weakness.
The patient will have severe unbearable pain.
Yeah. So, you
It
can.
is not just numbness, severe pain. You should make him immediately admit and put him on rest. Right. The one was that. What is the PSA level mentioned where you can do straight treatment without any cutoff level mentioned?
More
In
than
this
100.
case, it is 200.
More than 100.
Yes, 1,000 is what I heard of. More than 1,000 PSA. There is no other disease which can cause a raise in PSA to that level, other than CFS.
Okay, so
Giving biopsy.
Uroflowmetry showing poor average flow with straining pattern. Post-wide residue is there. Significant post-wide residue is there.
What is that significant?
More than 10% or 30 ml.
Let's say 40 ml residue. We don't know what is significant.
Here and there.
I agree. I know, I saw that. Let's say residue.
Okay.
It's like that significant word is misused by the sonologists. Significant post-word.
Right. So trust-guided prostate trust-guided prostate biopsy is and it is showing adenocarcinoma of the prostate with Gleason's grade of 3+4/7.
Comment on the biopsy report. What is your
So number of cores which they took, they have not mentioned, and percentage of core positivity is not mentioned, and perineural invasion.
How many
They have
courses taken also not mentioned?
Number of percent. Vascular and neural invasion they have mentioned, not there.
you see, some of those findings on pathology would be useful in a patient who you think you are going to go for aggressive treatment with curative intent,
Yes, sir.
right? So in this particular case, they may not have done more than 2 or whatever it is. They just report it, that's all.
Yes, sir.
So, the pathologist, you can make a senior pathologist there, maybe they just looked at it and said carcinoma of prostate, finished, because they must have told high PSA, we just want to know whether it is malignancy or not. Only problem is clinical data has been put as carcinoma of prostate and bladder. That is the only one. Why do you think they put carcinoma of prostate and bladder? Clinical diagnosis.
Clinical diagnosis, sir.
Yeah, they put the clinical data, carcinoma of prostate and bladder.
In the ultrasound, it is some findings maybe there, sir.
No,
Go back.
any other reason why they had this doubt?
So he was having microhematuria is there, so that may be again maybe because of prostate cancer also. They have mentioned that bladder, the diffuse wall thickening is there, 9 mm
Left hydrolysis.
with left hydronephrosis.
Yes. So,
That can be again maybe because of bladder outlet obstruction causing upper tract changes.
So when the bladder
watershed area, which is the watershed area where these diagnoses are difficult? They're not sure whether it's prostate cancer or whether it's bladder cancer.
So when there is a lesion at the bladder neck
Yes.
area.
So they were not even sure. But what is the sure sign here in this patient?
Left hydronephrosis.
Right.
That you can get in bladder cancer. The sure sign in this patient.
Clinical
My-
sign.
Arey Baba, the PSA man,
It was
PSA
prostate.
200, you won't get in bladder cancer.
Yes, sir. Hard prostate.
No,
If the PSA was in a gray zone, if the PSA was say in a gray zone and you had this finding, you're not very certain what it is, then you could be confused. Especially with unilateral hydronephrosis. Huh?
so
And
you
prostate
said,
infiltrating bladder base, you don't know, PSA is not spot on, it's here and there, so you can get confused.
bladder outlet obstruction with left side hydronephrosis. Do you agree with that?
That is less likely. More likely in this case, maybe because lymph nodes causing the ureteric obstruction. More likely.
But you said bladder outlet obstruction.
See, again, the way to answer that question is to answer it specifically. Prabhu's question, in bladder outlet obstruction, will you get left hydronephrosis? Yes or no? When you talk of bladder outlet obstruction, we're not talking of malignancy.
So upper tract changes can happen.
Left hydronephrosis.
Left. Generally speaking.
Bilateral is more likely.
Yes, that's right. So
Sure.
the way to answer this question is, sir, bilateral hydronephrosis is more likely in benign pathology due to causing bladder outlet obstruction. Finish, stop. Don't say lymph node, lymph node. Who wants to know all that, man? Then you will go into a different tangent and you still haven't answered the question. Just stick to the point.
Yes, sir.
Yeah. Then they'll ask you about lymph nodes, they'll ask you why this, that. Oh, they can go on endlessly, man.
Okay.
Finish the exam, get out fast.
Yes, but what do you want?
What do you want next? Tell us.
So I want to do a MRI already not. And also bone scan I want.
You want both, MRI as well as bone scan. Both you want.
Okay, good.
MRI pelvis shows.
Do we actually do both in clinical practice?
Yes, sir.
For metastatic prostate cancer.
Only bone scan.
Yeah, but like we discussed here, you would want an MRI to look at specifically
Lymph nodes.
lymph nodes.
One is there, see the focal sclerotic lesion in the left iliac bone.
Yes, sir. Multiple lymph nodes also.
You ask the MRI guys for a skeletal survey, they will do all that. You get reports. So
Yes, sir.
there was actually a very nice paper produced by one of the residents from Vedanayakam, who's a consultant in the UK, and he presented a paper at the Hyderabad conference where he looked at bone mets versus bone scan versus MRI, and showed clearly the superiority of the MRI in certain situations, especially when you're looking at bone marrow, when you're looking at whether this is degenerative or non-degenerative, the MRI seems to score better. Gokul presented that paper at the Hyderabad conference. So, anyway.
Next.
So what do you want to do now?
Bone scan.
Still you
You want a bone scan. Have you done a bone scan?
Not done.
Patient has para-aortic lymph nodes and all that.
Aortic, aortic cable, everything.
So will your staging anything change? And already one bone is mentioned.
Yes, sir. Metastatic carcinoma prostate. Yes. But for risk stratification, I want to know how many bones are involved, and also visceral metastasis. In this MRI, there is no visceral metastasis. So if it puts him into the high volume disease, then I can prognosticate the patient. And also treatment selection will be slightly different for high volume disease versus low volume disease.
So how will you treat this man now? What will be your treatment strategy for this man?
This is metastatic hormone-naive metastatic carcinoma prostate with high good performance status and
HSPC. Small
Yes, sir.
m HSPC. Metastatic hormone sensitive prostate cancer. Isn't it?
yes, sir.
Yes. So what's your treatment?
Good performance score and relatively more than 10 years of life expectancy. I would like to give him docetaxel with androgen deprivation therapy.
So that is chemohormonal. Why are you choosing docetaxel at this point? Any other reason? Is there any specific reason why you are choosing docetaxel now?
It is likely to be high volume disease, and that's why.
Not likely. You've got the MRI in front of you, man.
It is high volume disease, so that's why I'm.
Mainly nodal disease. Lots of nodes.
Yes, sir.
Yeah. If he did not have all these nodes, you could have chosen a different route.
Yes,
But
sir.
because he's got high volume disease with nodal involvement, your preference would be chemohormonal for this patient with good performance status. Okay.
Can I give radiotherapy to this patient?
No, sir.
Huh?
No, sir.
Why?
Radiotherapy is reserved for locally advanced prostate cancer.
Any other reason?
Any contraindication to radiotherapy?
Upper tract change.
Huh? No. Then you see why what was his presenting complaint, man?
So the genital swelling is
Genital swelling. Is
and
there
it
a
will
connection?
get aggravated.
That and the question, is there a connection between that and the question that was asked by?
Yes, sir, that further aggravates the lymphatic blockade and swelling will increase.
Yes, there is hydro, left hydro. Obstruction in the front. Chat box.
So you see this man presented with all that genital swelling and all, you give him radiotherapy now, you're going to worsen that swelling, isn't it?
Yes, sir.
Yeah, so it will become so brawny that he may not be able to clear it. That is the problem.
Okay, sir.
Okay?
Yes, sir.
So how many cycles of docetaxel do you do?
So I would like to give 3 cycles of docetaxel, sir, and assess the response with serum PSA and serum PSA, sir.
Now, how much you are planning? Let's say you are planning.
For 6 cycles, sir.
Yeah, you tell that first, and then you say, I will reassess this better. Because the patient would have planned the budget accordingly.
Yes, sir.
You will give only plain docetaxel or you will give something else with it? Do they give plain docetaxel or they give something?
Sir, that it has to be supplemented with the steroid. Sir.
Usually prednisolone, you have to give. Okay, that is all the TAX 3-2T study, famous study was. Okay, they combined it with.
Yes, sir.
Based on which study you are quoting that you start docetaxel straight away?
Based on this one, sir. Started study.
Sir, just mention one study. You didn't hear. Okay. That was the first study. Charted has come after that. Any other study?
And latitude also mentioned.
Latitude is for docetaxel?
No, sir. This one, sir. Stampede. 1 hour.
For these important studies, please at least remember what is written in the abstract. If you have not gone through the whole study. What were the outcomes of these studies? You should
No.
Okay.
So you said at the beginning, 10-year survival is good.
Yes, sir.
Metastatic also, you are very confident 10-year survival.
How much will it cost?
Yes, sir.
Is it something which is mentioned for metastatic disease, 10-year survival? Is good?
No, I told him.
Yes, sir.
Mentioned.
Yes, sir.
How many years do you think metastatic prostate people live? 10-year survival is for where you have a intent to treat, cure, curative lead. Metastatic, how can you at the beginning you are telling good survival 10 years? He already has lymph nodes everywhere. You don't know. And suddenly, let's say he dies of MI or something else in 2 years, then you is in trouble.
Well, he has, you give him this chemo hormonal therapy and his PSA comes down nicely. Alright?
Yes, sir.
His PSA comes down nicely, he's doing very well, he's very happy. And then after 1 year, again the PSA starts to go up. What will you do?
Sir, the stage I would like to get PSMA PET scan to look for the location where it is recurring.
So it's like recurring at one particular place. It's already metastatic. You want to see where it is rising. Oh, I'll tell you one particular lymph node has enlarged. Compared to MRI done 2 years back, now an iliac lymph node is enlarged. So you are specifically asking for PSA. That's why.
And I would like to start him on abiraterone along with the continued ADT.
Now, what will that Yamma, whatever, PSMA PET help you in change the management? Because you are specific.
Okay. The location of the PSA recurrent.
Oh, tell us the findings of the PSMA PET. What all can it show you?
So that shows PSA, the PSMA avidity, it will show in the form of SUV, SUV max and SUV mean.
No. What are the things that you can see in the PSMA PET on this patient? What are the findings, possible findings?
So before starting treatment, that prostate would be showing PSMA avidity and lymph nodes showing PSMA avidity and one bony lesion in the mentioned, and possibly other bony lesions are also maybe showing.
Oh, and we are talking of after 1 year now. After 1 year, his PSA is going to go up, and you said you will do PSMA PET.
See, you have a patient who has a localized disease.
Yes.
You have done some treatment, maybe radical prostatectomy, and his PSA is rising. You do a PSMA. Yes, I know. I want to know where it is recurred. Is it local? It is metastatic, whatever. In a patient, it is already you know that it is metastatic. What additional information I get by doing a PSMA PET? Is it unexpected that the PSA will rise after 1 year as suggested?
No. Not an
You expect it as a natural history, or you expect it as a
as a natural history.
then why you want a PSMA extra test? PSMA is indicated in a localized disease. When you want to say where it is. Now, let us say, as I said, right side lymph node is enlarged, aortic cava lymph node is enlarged. Are you going to change the management?
I'd like to get serum testosterone level, sir, as he is already on the ADT continued treatment. If it has become castrate resistant or not, I want to see that.
If it is not castrate resistant, what will you do?
Not
Not castrated.
Castrate. You only said no. I'll do serum testosterone to see if it's castrate level. It's not castrate level. What will you do?
So we can, I will add abiraterone treatment for that.
No. Would there be some reasons as to why do you want to add abiraterone when the castrate level is still not reached by your treatment? Your treatment was what? Chemo-hormonal, isn't it?
Yes, sir. Yes, sir.
Chemo-hormonal. What hormone did you use?
In this case.
No, what
Triptorelin.
hormone did you use?
Triptorelin, sir.
Huh? Triptorelin. Okay, you use triptorelin. And then the PSA the castrate levels were not reached. What will be your thinking process? Because you only said I will check serum testosterone to look for castrate levels. That's why I'm asking the question.
What is the level you are looking at?
15 testosterone.
Huh?
Yes,
1.5.
Yes, sir.
1.5 or 50?
Testosterone 50, sir.
No. Okay. So some 20 it is mentioned, some it is mentioned.
Oh yeah, but at the moment everybody is sticking to 50, but although some people feel it should be the lower range, 20, 25, whatever. Anyway. So it is not reached. So what will you do? Huh?
I will repeat the PSA once.
You repeat the PSA.
Yes, sir.
Testosterone has not reached castrate level.
PSA, I will repeat to check whether it is correctly.
Done at 3 different labs. Is that the answer? On the same day you want to repeat or what? How do you say that PSA is rising?
It was 0.01, it is 2.5. After 3 months, it is 2.5. Is that enough?
How do you define castrate resistance with the PSA? I don't want to go into the testosterone part. I want to ask about the PSA.
Raising PSA level in the absence of castrate level of testosterone.
No, this
Linear. You go and find out the definition of what rising PSA in metastatic cancer would be. You answer sir's question. It's not castrate. So what do we do?
Continue editing.
It's not castrate. With your triptorelin, castrate levels have not reached.
So you want to.
No, you don't want to do anything. With non-castrate testosterone levels, can you label them as castrate resistant?
No.
So what will you do about the testosterone? Okay. One option is consider orchidectomy. Any other drugs?
Degarelin.
One of the things that's the problem with some of these LHRH agonists is the maintenance of a cold chain. Of course, you're using triptorelin, which does not make a difference. So whether this fellow has actually taken the medication is the first thing that you want to do. If he's taken a drug called Eligard, then it needs to maintain the cold chain. And the effectivity of it gets lost if it is not given on time.
Okay.
So as Manish said, you want to be very sure that the hormonal part is done properly. Then orchidectomy is the way to do it.
Yes.
All right. Some people do subcapsular orchidectomy. All right.
Yes, sir.
And that also can, in some situations, keep the testosterone level not exactly castrate. In which case, you will have to probably go back and complete the orchidectomy because there could be still some outlying tubules which will be producing testosterone. So, 2 situations where you might have to go back in. Okay.
Okay, sir.
Right. How do we do a subcapsular orchidectomy?
will incise the like a paramedian incision.
Yeah, the testis in hand.
Paramedian incision. You are doing subcapsular.
Unilateral or bilateral?
Bilateral we are doing.
Okay, so you will either use a midline or you will use a transverse incision going across both sides. In the scrotum, which is better, a longitudinal or a transverse incision?
Transverse incision.
Why?
Vascular.
What vascular?
Vascular supply will be not cut off.
You have to tell me what the vascular supply is like. Not red. Okay.
Cosmetically, does it make a difference?
Okay. So you've done one incision, you've got the testis in hand. Then
We have to incise the tunica albugina and remove the seminiferous tubule.
You clamp the cord. You clamp the cord during this process.
Yes, sir. Clamp the cord and remove the
Clamp the cord.
why do you want to clamp the cord?
blood. The testicular artery can bleed.
Also, if you clamp the cord, you will use a crushing instrument to clamp the cord.
Non-crushing.
Non-crushing instrument will clamp the artery with the vas going there. Have you read subcapsular occipectomy? Yes or no? So then you cannot guess an operative procedure. Please find out how it is done.
What is the advantage? Why people have stopped using it? So in the natural history, after how many years usually it becomes castrate resistant? I mean, after the initial hormonal treatment. No, when you counsel a patient that I'm starting your hormonal treatment, the PSA will come down. You will also say that, it will start rising.
After 3 years.
2 years.
18 to 24 months.
It will start rising.
This thing is not.
Otherwise, he will change you because you have not told it at the beginning. Oh, now the PSA is rising. So the doctor is something. You tell all the natural history of what once you start an hormonal treatment, additional treatment you will add. Okay, I think.
We'll close, sir. Thank you.
Thank you, sir. Thank you, sir.
Thank you.